Hello, can you hear me?
Yes, sir.
So today we'll start with the last of the electrolyte imbalance topics, that is calcium homeostasis. As I told you, potassium, calcium, phosphate, and proteins are major intracellular ions, of which potassium and calcium are cations, phosphate and proteins are anions, while sodium, chloride, and bicarbonate are major extracellular ions. This calcium, it is mostly intracellular and 99% of the calcium is present in bone. So whatever the total body stores are there, of all the body stores, 99% of the calcium is sequestered in the bone in the form of hydroxyapatite. Now this calcium in the bone is obviously required for development of skeletal strength. It is for the bone strength because it forms the matrix of the bone, but also it serves as a reservoir. Whenever there is a lot of calcium in the body, in the blood, this calcium gets taken up by the bone, gets stored there, and whenever there is a state of hypocalcemia, the bone will release this calcium back into the circulation. So it also acts as a reservoir, but it is also required for the bone strength. And whatever the calcium we measure, it is a 1% of the calcium. Right? So what we measure is just 1% of total calcium that is present in the body, just like potassium, where we measure only 2% of total potassium present in the body. And this 1%, what we measure is called as total serum calcium. And this total serum calcium is normally in the range of 8.5 to 10.5 milligram per deciliter. For every deciliter of blood, there is 8.5 to 10.5. But it doesn't mean that all this entire 1% of calcium which is present extracellular is used up for physiological functions. Of this 1%, if you take this 1% as 100%, only 50% is in the form of ionized calcium. Now, this ionized calcium is the physiological form of calcium, which is responsible for all the physiological actions of calcium. And certain laboratories, in fact, most of the laboratories can measure this ionized calcium directly. And this ionized calcium is in the range of 4.6 to around 5.2 mg per deciliter. So, it is this ionized calcium which is responsible for physiological actions. So whatever the tetany we get or hyperreflexia we get or cardiac effects, all are because of changes in this form of the calcium. Now rest 50% of the calcium, 10% of which lies in chelated form. So, chelation means whenever the ions combine, it is chelation. So because it is a cation, it can combine with calcium phosphate. It can combine with phosphate and form calcium phosphate. It can be in the form of calcium oxalate or it can be in the form of calcium carbonate. So this 10% is a chelated form where it combines with phosphate, oxalate, carbonate and forms precipitations. And this is how it is absorbed and transported. So this chelated form helps it to get absorbed from the gut and get transported between the tissues. Now, the rest 40% is protein bound, right? Because proteins are anions, calcium is a cation. It is the form which is present in the blood in the form of proteins, right? Now, this can be present as a ECF or it can be present in ICF. Now, this does not form the ECF form. In ICF, calcium can be bound to calmodulin. Within the cell, the calcium is bound to the calmodulin, which is also a protein. But this 40%, which represents the extracellular calcium, it is mainly bound to the albumin and globulin. So the binding to globulin is very minimal. So mostly it is bound to the albumin. So out of this total serum calcium, what you measure, that comes out to be 8.5 to 10.5, 40% of this is albumin bound. So whenever you get a serum calcium level, the first thing you should be looking for is a albumin level because every 1 gram per deciliter of reduction in albumin reduces calcium by 0.8 mg per deciliter. So if you take albumin as 4.5 to be normal, from 4.5, every 1 gram reduction in the albumin reduces calcium by 0.8 mg per deciliter. We'll see how to correct those as we progress further. Right? So this is all about calcium. Now, what this ionized calcium does is, ionized calcium mainly serves muscle contraction. And this is also responsible for phosphorylation of enzymes. And whatever the hormones are released in the body for mediating the effects of hormones, ionized calcium is required. Also, ionized calcium is required for activation of protein kinases. Right? So, ionized calcium is required for muscle contraction, phosphorylation of enzymes, mediating the hormonal effects, and the activation of protein kinases. Muscle contraction slightly varies between a skeletal muscle and a smooth muscle and a cardiac muscle as to how this calcium causes muscle contraction. Right. So first we'll start with skeletal muscle. Whenever, say, for all muscle contractions or whatever has to happen, all you need is a action potential. So whenever the action potential reaches a skeletal muscle cell, when it reaches skeletal muscle cell, this will cause the release of calcium from the intracellular stores only. So releases calcium from sarcoplasmic reticulum, right? So there is a cell, and inside this cell there is sarcoplasmic reticulum, and calcium is present in this sarcoplasmic reticulum. Whenever the action potential comes and reaches this cell, there is a release of this calcium from the sarcoplasmic reticulum. So now calcium is free in the cell. Now this released calcium will cause phosphorylation of myosin. So this combines with calcium, combines with tropomyosin, and it causes the phosphorylation of myosin. Now this myosin can bind with actin, and once myosin actin binding happens, there is muscle contraction. So what you need to understand here is whenever action potential reaches the skeletal muscle, the calcium is released from the endogenous stores of the sarcoplasmic reticulum. But what happens in a smooth muscle is, as action potential reaches the cell, this action potential, just like in skeletal muscle, will release calcium from sarcoplasmic reticulum. But also, this action potential will activate the ligand gated and voltage gated sodium calcium channels. So the as it happens with the skeletal muscle, the release from the sarcoplasmic reticulum also happens, but along with that, it will also activate ligand gated calcium channel and voltage gated calcium channel. When this gets activated, the calcium will enter inside. Right? So there is intracellular calcium release also. There is influx of calcium from the ECF also. Now, when this calcium enters inside, in smooth muscle, this calcium binds to calmodulin. It is a calcium modulating protein, so it is called as calmodulin. It will form these complexes, which will activate the myosin light chain kinase that will phosphorylate myosin, and this phosphorylated myosin binds with actin, and actin causes muscle contraction. That's all. So this is what happens in a smooth muscle. But what happens in a cardiac muscle is that, so in a cardiac muscle, when the action potential reaches a cardiac muscle cell, now this will cause influx of the calcium. And this influxed calcium, so whenever there is action potential that reaches a cardiac muscle, it causes the calcium to enter inside. And this calcium that enters inside will cause the release of calcium from the sarcoplasmic reticulum. Now then the same things happen that lead to muscle contraction. Right? So this is the basic difference. So what happens in a skeletal muscle is that once action potential reaches the cell, this will release calcium from sarcoplasmic reticulum. And in smooth muscle, action potential reaches, it will release calcium from the skeletal sarcoplasmic reticulum. Along with that, it will also cause influx of calcium through voltage gated and ligand gated calcium channels. Both of them form calcium colmodulin complexes that will activate the myosin light chain kinase that phosphorylates the myosin that interacts with the actin. But what happens in cardiac muscle is once action potential reaches, this causes the influx of the calcium, and whatever the calcium that has influx, it will stimulate the release of intracellular calcium. So this is just a basic difference how calcium acts in different muscle groups. So now, because this calcium is involved in the all this phosphorylation, activation of protein kinases, and physiological functions, you need to understand how this calcium is regulated. Right. So this calcium, unlike sodium and potassium, calcium is heavily under the hormonal regulation. So there are three important organs and three important hormones that regulate the calcium. These three important organs are gut, kidney, and bone. Right? From the gut, calcium has to be absorbed. Now, this calcium is absorbed mainly by vitamin D3. Right? So, the most important factor for absorption of calcium from the gut is vitamin D3. The recommended dietary allowance of calcium, because it is Ca plus 2, you can take it as 2 gram. It is anywhere between 1 to 3 gram. 2 gram per day of calcium is what we take in. Out of this 2 gram per day, only 200 to 300 mg is absorbed. Right? So majority of the calcium what we take is passed in stools only, but only 200 to 300 mg of calcium is absorbed. Now, once this calcium is absorbed, it can go into the bone. Right? In the bone, if there is stimulation of osteoblast, now osteoblast is what makes the bone. So osteoblast will take all the calcium from the blood and it will put it into the bone. Right? So whenever there is a increased osteoblastic activity, it takes all the calcium from the blood and puts into the bone, so the serum calcium level reduces. Whenever there is increased osteoclastic activity, whatever causes increase in the osteoclastic activity, this will cause the resorption of the bone and it puts all the calcium back into the blood. Right? So that will reduce the serum calcium levels. So it is simple. Whenever osteoblast increases, serum calcium reduces. Osteoclast activity increases, serum calcium level, sorry, serum calcium level increases because it takes all the calcium from the bone and it puts into the blood. In kidney, once the calcium is filtered through the glomerulus, this passes through the ascending loop of Henle. Then there is distal convoluted tubule, and then there is collecting duct. Right? So there is collecting duct. So whenever there is increased calcium in the body, now this increased calcium makes the kidney to increase to inhibit reabsorption of the calcium from these structures, right? Which is ascending loop of Henle, distal convoluted tubule, and the collecting ducts. The calcium is in reabsorption is inhibited, so that calcium is lost in urine, which increases the urinary calcium and it reduces the serum calcium. And the opposite happens when there is reduced calcium in the kidney, where there is stimulation of reabsorption of calcium, and that will reduce the urinary calcium levels and increase the serum calcium levels. Right? Now, the three hormones are, as I told you, vitamin D3, parathyroid, and kidney. No, sorry, and calcitonin. So now this parathyroid gland, whenever there is a reduced serum calcium in the body, this serum calcium will go and stimulate the parathyroid gland. This parathyroid gland will release parathormone. Now this parathormone acts onto the bone And in the bone, it stimulates. All it wants to do is increase the serum calcium level. Because calcium is reduced, it wants to increase the serum calcium level. So all it does is it stimulates the bone, osteoclast of the bone, which will cause the resorption of the bone. And as a result, all the calcium from the bone will be thrown into the blood. Right? So calcium comes into blood. Also, this parathormone will act onto the kidney. Right? It does not want kidney to lose calcium, so it increases the reabsorption of calcium from those three structures. As a result, there is increased calcium in the blood. Also, parathyroid makes kidney to secrete to produce more vitamin D3, and this vitamin D3 will increase calcium absorption from gut. So calcium resorption from bone is increased, calcium reabsorption from the kidney is increased, calcium absorption from the gut is increased. So as a result, all of this will throw the calcium into the blood and increases the serum calcium level. So that's what is the work of parathyroid hormone. So whenever there's reduced serum calcium, parathormone is released and that increases the serum calcium levels. Now, vitamin D3. This exists in the form of, from the cholesterol, there is synthesis of vitamin D. In the liver, one hydroxyl group gets attached to the vitamin D and it forms 25 hydroxy vitamin D. Now, when it goes to the kidney throws one more hydroxyl group at this structure. So it becomes 125 dihydroxy vitamin D3, right? So there was vitamin D at 125 position, liver threw a hydroxyl group. At one position, kidney added a hydroxyl group. So it became 125 dihydroxy vitamin D3. Now, this 125 dihydroxy vitamin D3 is what is called as activated vitamin D, or it can also be called as calcitriol. Right? So you tell calcitriol or activated vitamin D, which is the last end product of vitamin D3, which is most potent absorptor of calcium from the gut. So it has 2 points. One is it increases the calcium absorption from gut. Also, it increases calcium resorption from bone by stimulating osteoclastic activity. So both of this will increase the serum calcium levels. Now, when the serum calcium levels get increased to more than normal, that will stimulate the parafollicular C cells in the thyroid. And these parafollicular C cells of thyroid will secrete a hormone which is called as calcitonin. Now, this calcitonin has opposite effects. It acts on the bone, it stimulates the osteoblasts. So, what these osteoblasts do, they take all the calcium from the blood and they put it back into the bone. Right? So, that reduces serum calcium levels. They act on the kidney and they inhibit reabsorption of calcium. As a result, the serum calcium level reduces and there is increased excretion. They also inhibit absorption of calcium from gut. Now, that will also reduce the serum calcium levels. Right? So, this is how these three hormones play a role, of which the parathormone and calcium are mainly regulated by endocrine system. But the difference with vitamin D is it is not just regulated by endocrine system, but it is also dependent upon the exposure to the sunlight and also for dependent upon the dietary intake. So this is how calcium homeostasis is maintained in the body by the help of these three hormones and these three organs. Is this clear? Hello.
Yes, sir.
Yes, sir.
Now we'll talk about hypocalcemia. So to call it as hypocalcemia, now because most of the laboratories are giving you the ionized calcium levels also, which is actually better than total serum calcium. Better be adequate with both of them. So the total serum calcium of less than 8.5 mg per deciliter is hypocalcemia, or ionized calcium of less than 4.5 mg per deciliter. Right? So either it is total serum calcium or ionized calcium, both this is less than 8.5, less than 4.5 is hypocalcemia. There are numerous causes for hypocalcemia. So if I want to categorize them, I would categorize them as PTH related, and I would call them as others. I would not call them as PTH unrelated because in some way, either indirectly also they are PTH related. So I would classify them as other causes. I'll just list out the causes, then we'll discuss how these happen, right? So other causes would be a pseudo hypocalcemia, which is encountered especially in a surgical patient most often, or it can be because of hypomagnesemia, or it can be because of hypermagnesemia. It can be because of hyperphosphatemia. It can be because of, I'll tell you how acidosis and alkalosis cause. So I'll just put it as acidosis and alkalosis. So if you want to pick one, pick alkalosis, right? So out of these two, you pick alkalosis. I'll just tell how these interact. So acidosis alkalosis state and tumor lysis syndrome or rhabdomyolysis, osteoblastic mets, acute pancreatitis, drugs, pregnancy, blood transfusion, pseudohypocalcemia, hypomagnesemia, hypo or hypermagnesemia, hyperphosphatemia, acidotic and alkalotic state interactions, tumor lysis syndrome, rhabdomyolysis, osteoblastic mets, acute pancreatitis, even sepsis, severe burns, trauma, critical illness. So all of this can cause hypocalcemia. So when it is PTH related, it can be either because of vitamin D deficiency, or it is because of chronic kidney disease, or pseudo hypoparathyroidism. Right. So in vitamin D and CKD, actually there is increased parathyroid hormone, but there is reduced serum calcium. We'll discuss in a while. Or there can be reduced parathormone only. Now, this reduced parathormone can happen because of aplasia or dysplasia of the gland. It can be because of, again, one of the dysplastic syndromes of parathyroid is DGOT syndrome. It can be because of iatrogenic hypoparathyroidism, or it can be because of destruction of the gland, or it can be because of removal of the gland, or it can be because of autoimmune diseases. Right? So we'll all discuss this one by one. So first we'll start with others. Remember, the most common cause of a hypocalcemia would always be hypoparathyroidism. Right? So when it comes to other causes, we'll discuss pseudo hypocalcemia. As I told you, 40% of calcium is albumin bound. So whenever there is reduction in albumin, the total serum calcium also reduces. Right? And whenever albumin is less than 4.5 gram per deciliter, every 1 gram per deciliter of reduction in albumin will reduce total serum calcium by 0.8. Right? So because it is bound to the albumin. So if I want to tell if the albumin of the patient is 3.5, so 1 gram is reduced, calcium would be reduced by 0.8. If it is 2.5, 2 gram is reduced, then it would be 0.8 into 2, which is it is reduced by 1.6. If 3 gram is reduced, it would be reduced by 0.8 into 3, which is 2.4. Meaning, to calculate, what you need to understand is it reduces by multiplication of what is the deficit, right? So if 2 is reduced, you need to multiply it by 2. If 3 is reduced, you need to multiply it by 3. So whenever you see that the patient has hypocalcemia, like as I told you, whenever the patient has hyponatremia, the first thing you should check for is glucose level. Whenever the patient has hyperkalemia, you should check for ECG. And if ECG is normal, mostly it is a lysis of the sample. So similarly, whenever there is a hypocalcemia, you first check for albumin. So if the albumin is low, then what you need to do is you calculate the corrected calcium. Now this corrected calcium would be the total serum calcium, which you got it as low because albumin was low. To this, you need to add the correction. What would be the correction? Which is nothing but zero point 0.8 times the change. Right? So that is the physiological basis of the formula. So what would this change be? So it is total serum calcium plus 0.8 into the change is we take standard as 4.5 minus the current albumin of the patient. So if you get a patient with serum calcium of 7, you think this is hypocalcemia, but the albumin of the patient is 2.5. Then you need to check corrected calcium. So corrected calcium would be total serum calcium is 7 plus zero point 0.8 into 4.5 minus 2.5, which would be 7 plus zero point 0.8 into 2, which is 1.6, which is comes to 8.6. So the actual albumin of this patient is 8.6, but because, sorry, actual calcium is 8.6. But if you think that it is 7 and you treat hypocalcemia by IV injections, then it would be hazardous. So always whenever you look for hypocalcemia, you check for albumin. And if albumin is low, please use this formula to get the corrected calcium. Now, if you don't want any of this to happen, directly check ionized calcium, right? Because ionized calcium is not at all albumin bound. It doesn't make any difference. So ionized calcium will be normal. This is called a pseudo hypocalcemia. Next is magnesium abnormalities. So as I told you, magnesium would be anywhere in the range of 1.5 to 2.5. If there is hypomagnesemia, now this magnesium level becomes less than 1 mg per deciliter. So when it becomes less than 1, that will lead to parathyroid resistance. So parathyroid is released properly, but when it acts onto the kidney or bone or on the gut, the cells will not respond to it. So that will reduce the serum calcium levels. So hypomagnesemia induces parathyroid resistance and it reduces serum calcium levels. But if there is hypermagnesemia, right, of more than 6, now this will inhibit parathyroid secretion. Right? It suppresses the parathyroid secretion. Because parathyroid secretion is reduced, parathyroid is low, and this will reduce the serum calcium. So that's how both hypo and hypermagnesemia can cause parathyroid deficiency. Now, if you know about magnesium, so whatever reduces the magnesium should also reduce the calcium, right? So I told you about the drugs that reduce magnesium. If you remember, I told you to remember one antifungal, which was amphotericin B. I told you to remember one antibiotic, which is aminoglycosid. Also, one cisplatin, right? All of them reduce magnesium, and because they reduce magnesium, they reduce calcium, right? This is first class of drugs. Second class of drug would be a phoscarnate, right? This phoscarnate binds to calcium and it precipitates, right? Calcium has to be in the free form. It binds to ionized calcium, it precipitates, so it causes hypocalcemia. Third would be denosumab and bisphosphonates. Now, this denosumab and bisphosphonates, they inhibit osteoclast. So when osteoclast is inhibited, the release of calcium from the bone is inhibited. So that is why they will reduce the serum calcium levels, right? So these are the drugs which will reduce the serum calcium levels. Now, hyperphosphatemia. So whenever there is a increased phosphate levels, because phosphate is an anion, this phosphate will combine with the calcium and this forms a calcium phosphate. And this phosphate precipitates. Right? So that is why it causes hypocalcemia. Now, when does phosphate release happen? So this happens whenever there is rhabdomyolysis, whenever there is tumor lysis syndrome, whenever there is crush injury. So all the causes of the hyperkalemia. So all of them will, or whenever the phosphate is administered. So all of this will increase phosphate levels and this will cause hypercalcemia or whenever there is a reperfusion injury. So phosphate is mainly present intracellularly. Whatever causes the death of the phosphate, or death of the cell, will release all the intracellular elements, and phosphate is released, and it will cause the hypocalcemia, of which I want to tell about tumor lysis syndrome. Now, in a tumor lysis syndrome, especially it is seen if there is a blood tumor, leukemias or lymphomas or solid tumors. When these tumor cells are given chemotherapy, there is death of these cells. Now, when these cells die, they release all the intracellular things, right? Whatever is there intracellularly, potassium is there, phosphate is there, proteins are there. So when they release this, there will be hyperkalemia, there is hyperphosphatemia, and there is proteins are released which eventually form urea. So hyperuricemia will be there. And this increased phosphate will bind to the calcium and it will form calcium phosphate that precipitates. So hypocalcemia, right? But if you observe, calcium is also present intracellularly, right? So if this calcium is released, there should be actually hyperkalemia, hyperphosphatemia, hyperuricemia, because calcium is also released, there should be hypercalcemia, right? Okay, we'll take that this calcium binds to phosphate so that there is hypocalcemia. Because calcium is binding to the phosphate and causing calcium phosphate, the phosphate level should also reduce. Both of them are binding to each other, but calcium level reduces, but the phosphate level does not reduce. This is because if you see at the valency, calcium has a valency of 2. It is a bivalent ion. Phosphate has a valency of 3, right? So meaning if you want calcium to bind to the phosphate, because phosphate has a valency of 3, if there are 6 units that needs to be formed, only 2 units of phosphate is needed, but it takes 3 units of calcium, right? Because as you see here, Ca3 plus PO4 2, it is taking only 2 units of phosphate, but 3 units of calcium, right? So because phosphate is a trivalent ion, it needs more calcium than what calcium needs phosphate. So that is why more calcium will be used up and more phosphate remains. So it leads to hypocalcemia, not hypophosphatemia. Is this clear? Hello.
Yes, sir.
Next would be osteoblastic mets. Right? So these mets are mainly in females from the breast tumors and from the prostate tumors. And when they metastasize, they will produce osteoblastic mets. And these mets will use up all the calcium in the blood to form the bone. So they are bone forming mets. To form more bone, they need more calcium. So that will reduce the serum calcium levels. So that is how the osteoblastic mets, especially from the breast and prostate, will reduce the serum calcium levels. Right. Now, what happens in blood transfusion? So I told you, especially in a massive transfusion class. So whenever the blood is transfused, the most common storage what we use anticoagulant is CPDA. So this CPDA contains citrate. Now this citrate in the blood is a form of sodium citrate. This citrate will go and bind to the ionized calcium and it forms calcium citrate complex, which precipitates and is not useful. Also, I told you this because there is sodium citrate, it will increase the bicarbonate levels, right? 1 unit of blood, if you remember, contains about 23 milliequivalent of bicarbonate. So, whenever there is increased bicarbonate, that leads to metabolic alkalosis, and this metabolic alkalosis leads to hypocalcemia, right? So whenever there is increased bicarbonate, that leads to metabolic alkalosis, leads to hypocalcemia. Now you transfuse lots of blood to lots of patients. You might have not seen hypocalcemia in these patients. Now this happens only when the kidney is unable to clear bicarbonate. Right? Now when the kidney doesn't clear bicarbonate, either the kidney is failing or the load is so much that the kidney is unable to clear, even if it is normal. That happens in a massive blood transfusion, right? So that's why it was the consequence of a massive blood transfusion. So in massive blood transfusion, there's so much load that kidney is unable to clear. In CKD, even for a normal blood transfusion, the kidney is unable to clear it because the kidney is not functioning properly. So that is when that leads to hypocalcemia. Now we'll discuss to acidosis, right? So if you ever forget, you can remember that acid, D for acid, acid decreases calcium binding to albumin. So when the calcium binding to albumin reduces, it will increase the ionized calcium, right? So that can lead to hypercalcemia. But alkalosis is what is reverse, right? Where there is hypocalcemia. Now, this is a way to remember that acid decreases, D for decreases, but I don't believe in mnemonics. Understanding would help you remember better. So whenever there is acidosis, what does it mean? So acidosis means there is increased H plus ion in the extracellular fluid. Now H plus is a cation, calcium is a cation, albumin is a anion. So all the proteins are negatively charged. So these are cations, this is negatively charged. Both H plus and calcium fight to bind to the albumin. So whenever the H plus is more, most of the albumin will be taken by H plus. So the calcium cannot bind to the albumin. So the free calcium increases and calcium exists in the form of ionized calcium. Right? So whenever there is alkalosis, there is reduced hydrogen. So when the hydrogen reduces, so increased bicarbonate will eventually lead to reduced hydrogen. So whenever the hydrogen ions reduces, now there is nothing for albumin to bind to it, right? Because the place that was occupied by hydrogen is empty. More and more ionized calcium will come and bind to the albumin, and that will reduce the amount of ionized calcium that is present, and you get a hypocalcemia. So this is simple. That is why whatever causes alkalosis will lead to effects of the hypocalcemia. Now, this is equal to that of albumin, where the total serum calcium and the ionized calcium vary. They do not match with each other. But here there is no formula to correct it. So for the best way, whenever you suspect a patient with metabolic acidosis or alkalosis and there's hypocalcemia, the best way is to get a ionized calcium. Right? That will tell you truly whether there is hypocalcemia or not. Right? Is this clear? Hello.
Yes, sir.
So the next would be what happens in acute pancreatitis. So whenever there is acute pancreatitis, this acute pancreatitis will cause the release of enzymes. These enzymes will auto-digest the mesenteric fat. Right? See, what basically the pathology of pancreatitis is that pancreas has these fat digesting enzymes which should be released into the duodenum. They digest the fat in the duodenum. But in pancreatitis, there is release of these enzymes into the pancreatic tissue, which eventually seep out of the pancreas into the peritoneum. When these enzymes seep out into the peritoneum and there's premature activation of these enzymes, they, whatever, wherever fat is available, they just keep on digesting. So these auto digest mesenteric fat. And you know, when fat is digested, it is broken down into fatty acid and glycerol. Now, wherever there is fatty acid available freely, calcium comes and binds to it, right? And this will lead to the saponification. That is why in earlier days, when there was in pre-ultrasound era, so most of the perforation cases were considered, most of the acute pancreatitis cases were thought to be perforation because of the clinical similar clinical presentations. They used to open up this abdomen, and all through the mesentery they used to find white deposits, so which were suggestive of saponification, which was very common in the pre-ultrasound era. So because of this, calcium is all used up here, that will result in reduced serum calcium. Right? So this is what happens in a acute pancreatitis. There is a reduction in serum calcium because it is used up in saponification of the fat. Now, in case of a severe sepsis or critical illness or burns, as I told you, all of them will eventually lead to hypermetabolic state. And whenever there is hypermetabolic state, along with glucagon and insulin, catecholamine is released. This catecholamine will cause the intracellular shift of calcium. So whatever the calcium was there in the blood, it took all the calcium from the blood and it put into the cell. So because there is an intracellular shift of the calcium, the serum calcium level reduces. So this is the mechanism in any critical illness, in any burns, any major trauma, there is a reduction in calcium because of the hypermetabolic state. Along with that, if you remember, sepsis is the state where there is hypoalbuminemia. Now, this hypoalbuminemia can also lead to serum reduction in serum calcium. This is second reason. And the third reason would be there is reduced PTH secretion in sepsis, and there is magnesium dysregulation. So these are the primary causes for reduction in the calcium level: hypoalbuminemia, reduced PTH secretion, magnesium dysregulation, and reduction and the catecholamine synthesis. So all these are the things which will reduce the serum calcium levels in a state of sepsis. In pregnancy, of course, the nutritional demands are increased, and if those demands are not met, if the dietary calcium intake is not good, that will lead to the deficiency, especially if it is associated with the vitamin D deficiency. So these are all the other causes which can lead to hypocalcemia. But the most important cause would be, or the most common cause would be hypoparathyroidism. Whenever the serum parathyroid hormone is reduced, it will reduce the calcium levels. Now, this can happen. The problem is with the gland only, right? Like in case of Degot syndrome, where there is hypoplasia of the gland, or aplasia of the gland. So all these are the symptoms where there is problem with the gland only. And second is the gland is destroyed by autoimmune process. Now, whenever the calcium is less, this reduction in the calcium should be sensed by the parathyroid gland so that it can release the parathyroid. Now, there is less calcium in the body and the gland is not at all sensing it, then obviously parathyroid hormone release will be inhibited. There is no increase in the parathyroid hormone. This happens because of destruction of calcium sensing receptors, right? The fluctuations in the level of the calcium is not sensed by the gland at all. Now, autoantibodies are formed against these calcium sensing receptors, which will destroy these receptors so that the gland will not sense it and it will not release the parathyroid levels. So that is why there is reduction in parathyroid levels. Now, this can be occurring only in the parathyroid. So it is called as isolated autoimmune hypoparathyroidism. Okay, or it can be a form of polyglandular autoimmune hypoparathyroidism type A. Right? So, where there is autoimmune hypoparathyroidism, along with that, there is adrenal insufficiency and there is mucocutaneous candidiasis. Right? These three are clubbed together, and this is called as polyglandular, because two glands are involved, polyglandular autoimmune hypoparathyroidism type A. So this can happen. Now, these receptors don't get destroyed, but they are congenitally absent. So there is congenital absence of calcium sensing receptors. So whenever there is a congenital absence, that can also lead to the low parathyroid levels. So these are two receptor related. And third is parathormone is released. Now it acts onto the receptors, but after acting to the receptors, nothing will happen. That is called as post receptor resistance. Right? Now, this post receptor resistance, so it will bind to the receptor, but after binding to the receptor, there is no action of parathormone. So, this post receptor resistance is called as Albright osteodystrophy. This is called as Albright osteodystrophy, or it is a form of pseudo hypoparathyroidism. Parathyroid hormone is sufficient. In fact, it can be increased also because of negative feedback, but there is post receptor resistance, so that is why it is not active. But of all these, the most common cause for hypoparathyroidism would be iatrogenic. Now, this iatrogenic can happen while doing radical neck dissections, where the parathyroid hormone is removed, or it can happen during total thyroidectomy. Now, in total thyroidectomy, there is 2% risk of hypoparathyroidism. Now, this is because of removal of parathyroid, which is very rare. So, parathyroid is usually well seen if adequate principles of dissection are followed, and removal is very rare. But most commonly, it will be due to ischemia. Now, ischemia happens because if this is a thyroid, and you know that inferior thyroid artery enters from the middle, right? So it is the inferior thyroid artery enters from the middle of the gland into the thyroid. Now, on the either side of this inferior thyroid artery are present the parathyroids, and these parathyroids are supplied, both the superior and inferior parathyroids are mainly supplied by the inferior thyroid artery. So if you want to ligate this, the concept of polar ligation is gone. Either you ligate it at the superior pole or the inferior pole. You do not ligate the major vessel. Always what you do is you ligate the capsular branches. As they enter into the capsule, each superior and inferior branch divides further into the anterior and posterior branch. So you either ligate it or you burn it with a bipolar cautery. When you do not do that and you ligate it proximally here, that will cut off the blood supply to the parathyroid and leads to transient ischemia of the parathyroid, leads to transient hypoparathyroidism, which usually gets resolved in 6 weeks to 6 months because there is formation of collaterals from the superior thyroid artery. Right? So that is the most common cause of hypoparathyroidism. So these are all the conditions where the parathyroid hormone is reduced. Right. So as whatever I discussed in last slide, right? If it is CASN deficiency or absence or destruction, in all those conditions, parathormone is actually reduced. But even with increased parathormone, there can be reduced serum calcium. Now, this happens in case of chronic kidney disease, right? Whenever there's a chronic kidney disease, so this will cannot reabsorb calcium. Because it cannot reabsorb calcium, there is reduced serum calcium. Now, this reduced serum calcium will try to increase the parathyroid hormone levels, right? So that is why there is increased parathormone, there is reduced serum calcium. Now, this parathormone wants to act on the kidney and increase the reabsorption, which is not possible because the kidney is not functioning. So, as a result, the positive feedback keeps on increasing and parathormone increases. Also, if there is a vitamin D deficiency, vitamin D deficiency can happen because of malabsorption, because of reduced dietary intake, right? So reduced dietary intake because of malabsorption or because of reduced sunlight exposure, I am vitamin D deficient. So all these things can happen because of vitamin D deficiency. All of that will again reduce serum calcium level. Because serum calcium level is reduced, it will stimulate parathormone levels to be increased, right? So these are two conditions. Also pseudo hypoparathyroidism. So even then there is parathyroid hormone normal or it can be increased because of positive feedback. So these are all the conditions that would cause a hypocalcemia. So the list is too long, but if you stick to the basic principles and remember how they cause hypocalcemia, that would be easy, right? Is this clear?
Yes, sir.
Whenever there is hypocalcemia, the symptoms will not be severe. The patient might have some hyperreflexia or there can be some cramps, but the ionized calcium reduces to less than 2.5 mg per deciliter. Now, this will cause serious, so which would be equivalent to less than 7 if it is a total serum calcium, which will cause serious neuromuscular disorders and cardiac disorders. So, because calcium is required for cardiac muscle contraction, there is no calcium, it will reduce the force of contraction and eventually the heart will fail. This is what happens. And you take ECG, low calcium is always associated with prolonged QT, right? Which also happens in low magnesium. This torsionary pointers can happen. Ventricular fibrillations can happen, heart blocks can happen because it interferes with the conducting system of the heart, right? So the cardiac muscle is involved or the conducting system of the heart is involved, where it reduces the heart contraction and induces heart failure, or in the conducting system of the heart, it leads to arrhythmias, especially torsionis prepontis. Neuromuscular symptoms can be hypocalcemia can lead to seizure, especially in pediatric age group. Whenever there is a seizure, first thing we check is glucose. Second would be a calcium levels. So it can lead to seizure. It can lead to stridor, right? Also, the good way to remember the alkalosis and acidosis would be whenever the patient is hyperventilating, you can see that the patient will go into the spasm, carpopedal spasm. This is because when usually females, when they hyperventilate, carbon dioxide is washed away. So when carbon dioxide is washed away, that leads to alkalosis. Alkalosis reduces the hydrogen, effective hydrogen ions that are available. So albumin is relatively free. The calcium will come to bind to this albumin so that ionized calcium reduces and that induces the spasm, right? So hyperventilation causes carpopedal spasm in this manner. So there can be muscle spasm which can lead to tetany. Also, there can be hyperreflexia. So it can also lead to the hyperreflexia. So two signs for hyperreflexia would be all of you know Schwarzschild and Trousdale's sign. So Trousdale's sign is when you elevate the patient's BP to more than 200, hold it for 5 minutes there. You can see there is carpopedal spasm. So carpopedal spasm is actually the wrist is in flexion, the thumb is in flexion, but the metacarpophalangeal joints are also in flexion. Only the interphalangeal joints are in extension. So that is a classical carpal spasm. Spastic sign would be to tap over the front of the ear that will cause ipsilateral facial twitching. It is just that all these are hyperreflex symptoms. So these symptoms happen whenever the ionized calcium gets reduced to less than 2.5 mg per deciliter. Right. So how to go about it? You made a diagnosis of hypocalcemia. The serum calcium is reduced. The first thing you should be checking is for albumin levels, right? So if the albumin levels are reduced, you either check for ionized calcium level or you measure corrected calcium. Now, if the albumin levels are normal, it would be a true hypocalcemia. When it is true hypocalcemia, this true hypocalcemia may be because of either reduced magnesium or because of increased phosphate, right? So the next thing you should check for is magnesium and phosphate levels. So if both of them are altered, you find the cause for them. If both of them are normal, then depending upon your clinical symptoms, you start further investigations, right? So this is how to work up for a hypocalcemia. Coming to the treatment aspects. So if the patient has got acute symptomatic severe hypocalcemia, so in such patient, you initiate IV treatment, right? IV treatment can be in the form of calcium chloride. It can be in the form of calcium gluconate. So this calcium chloride contains 3 times more calcium than that of a calcium gluconate. But the problem is rapid infusion of this calcium chloride would lead to thrombophlebitis. And because of this thrombophlebitis, it gets extravasated and it causes tissue necrosis. Even though it contains good amount of calcium, because it causes thrombophlebitis and tissue necrosis, we do not use calcium chloride. We give calcium gluconate, right? So calcium gluconate is given in the form of IV. It has to be given either in NS or in dextrose. But NS is what we usually prefer. Do not give it in the fluids that contain bicarbonate or the phosphate like RL, right? Do not ever give it in RL because it forms calcium carbonate and calcium phosphate and it precipitates. So there is no use of it. What we need is a elemental calcium. So when you treat this patient who has got severe hypocalcemia, you take calcium gluconate and you give it 200 to 300 milligram of elemental calcium has to be given in 10 minutes, right? So usually what we do is there is a rule of 10 ml of 10% calcium gluconate added to 100 ml NS and given over 10 minutes. And after you give this, you look for ECG. If ECG's changes are present, you give another dose of bolus. If ECG is normal, you put them on maintenance dose, which would be to give 1 mg per kg per hour. Right? So this is how you manage calcium deficiency in severe state. If it is associated with hypomagnesemia, you give 2 gram of magnesium sulfate over 15 minutes, as we discussed, and then you can give at a rate of 1 gram per hour on first day, right? And on second, third, fourth, fifth day, you can reduce it to total of 5 gram per day. If it is associated with hyperphosphatemia, especially if the patient has got tumor lysis syndrome, the only way to deal with hyperphosphatemia would be hemodialysis, or else to flush out this phosphate, you can add NS. But when you give NS along with flushing out of phosphate, it will cause dilution of calcium and it further reduces the calcium levels in the body, causing severe of hypocalcemia. So along with NS, what you need to add is acetazolamide, right? So there was calcium was reduced because of increased phosphate. So to flush out this phosphate, you added NS, but NS will cause dilution and it will further reduce serum calcium levels. So that is why you add acetazolamide, right? Acetazolamide is a carbonic anhydrase inhibitor, right? So which will convert all this bicarbonate into carbonic acid. Carbonic acid's conversion into carbon dioxide plus water. So what it eventually does is it will reduce the, so this entire reaction is managed by the, it is both ways, right? So this can happen in both ways, managed by the carbonic anhydrase. So what it does is it will inhibit the carbonic anhydrase enzyme, which will induce a state of acidosis because it causes depletion of the bicarbonate ions. And when it induces the state of acidosis, obviously more H plus will go and bind to the albumin, so more calcium is released. So that's how you manage. You give NS along with acetazolamide if there is hyperphosphatemia. Now, more importantly, how to manage chronic hypocalcemia. So chronic hypocalcemia is mainly thought to be because of PTH deficiency. Right? So you start these patients with oral calcium, right? So the most commonly cheaply available form is calcium gluconate, right? So this is the cheapest and most common form of the calcium for oral intake that is available. When you treat this hypocalcemia in a patient with PTH deficiency, make sure that your target should be 8 only, right? Even though 8.5 to 10.5 is normal, don't over treat these patients. Keep a target of 8 mg per deciliter because you are giving increased calcium to this patient, right? So whenever there is more calcium in the body, the kidneys will excrete more calcium, right? But if the patient had got good amount of parathormone, this would inhibit excretion of the calcium from the kidney. Because there is deficiency of the parathormone, the greater calcium you give, the greater will be the excretion of the calcium. When calcium gets excreted from the kidney, it remains in the nephrons. Because it is not getting reabsorbed, it remains in the nephrons and it induces nephrocalcinosis. Right? Because if parathormone was there, it would have prevented the urinary calcium levels, it would have reduced urinary calcium levels, and it would have prevented nephrocalcinosis. Because there is nephrocalcinosis, there is nephrolithiasis, which would eventually lead to ARF. ARF will further cause CKD, and when there is CKD, there is further reduction in the calcium levels. So, whenever you treat a patient of chronic hypocalcemia because of parathyroid deficiency, maintain a target calcium of 8, right? Do not increase it beyond 8. How to go about it is, so there is a patient of chronic hypocalcemia because of chronic hypoparathyroidism. Now, in this patient, you start this patient on oral calcium. You measure after 1 month, you measure serum calcium. Now, this serum calcium is less than 8. If it is more than 8, you just continue this patient on serum calcium, on calcium supplement only. If it is less than 8, you add vitamin D, right? Vitamin D3 is available in sachet form, in tablet form, and in liquid form. 50,000 international units once a week, right? So now the patient will be on serum oral calcium plus vitamin D. Now you measure after 1 month serum calcium again. Along with that, you measure urinary calcium. Now, if you find that the urinary calcium in such patients is normal, you continue these patients on oral calcium plus vitamin D. But if the urinary calcium is increased, right, then you need to add a drug which will inhibit the urinary excretion of calcium. So you continue these patients on oral calcium plus vitamin D3. Along with that, you add a thiazide diuretic. Right? What thiazide does is it inhibits the renal excretion of the calcium so that the blood calcium levels increase. Also, there is no risk of hypocalcemia. Now, when you add these patients on this, you measure serum calcium again after a month. Now, this serum calcium has reached a target of 8. Then you put this measure potassium levels in these patients. Because when there is parathyroid deficiency, there is hypocalcemia, hyperphosphatemia. Because phosphate has reverse effects as sort of the calcium. So there is increased phosphate in the body, there is hypophosphatemia. So this hyperphosphatemia, if it is more than 6, you add, now the patient is on oral calcium, the patient is on vitamin D3, the patient is on thiazide. Along with that, you add a potassium binder orally. Right? And then every 3 months, you measure serum calcium, potassium, and urinary calcium. Right? That is simple. Whenever the patient has got hypocalcemia, starting with calcium. If it does not reach 8, add vitamin D3. If it reaches 8 after adding vitamin D3, measure for urinary calcium. If urinary calcium is more, add a thiazide. After all this, you measure phosphate levels. If phosphate levels are high, you can add a phosphate binder. Right? So this is how you treat. So one last topic of about 2 to 3 minutes: how to manage hypocalcemia in a pregnant and breastfeeding female. Right? So as I told you, in pregnancy, because the calcium has to be utilized for the newborn also, there is more need for calcium. So there was a female. Now this female was on pre-pregnant dosage of calcium, oral calcium plus vitamin D3. Now this female conceived. Now, as long as she conceived, she is pregnant, you need to increase the dose of calcium and vitamin D3. Now, how you increase depends upon the titration, right? You keep on measuring the serum calcium level, try to maintain it at 8. So, if it is less, obviously it will be less if you continue the pre-pregnant dosage. So, that is why you increase the dosage. And once she delivers the baby, right? Once she delivers the baby, you see whether she is breastfeeding the baby or she is bottle feeding the baby. Now, if she is bottle feeding, she is not at all giving breastfeed, you reduce it to pre-pregnant dose because vitamin